Good morning, everyone. Thank you for joining us today and starting off your day with us. I'm Kelley Stoppels. I'm a member of Miller Johnson's employment section, and I'm joined today by my colleague and friend, Tim Gutwald. We're here today to talk with you about Michigan's Executive Order 2020-50 that was issued last week. And before we dive into that, we're going to start you off with some updates and general headlines for you to take with you as you start your day. So in COVID news, some U.S. states are allowing businesses to reopen. South Carolina has allowed retail shops as of Monday afternoon. Georgia is allowing gyms, places for haircuts, massages, etc., to open on Friday. And Tennessee's stay-home order will expire on April 30th. USC and the LA Department of Public Health released preliminary study results that found an estimated 4.1% of the county's adult population has antibodies to the coronavirus. This is 28 to 55 times higher than the number of people that the confirmed cases would indicate. In terms of the coronavirus statistics, Michigan is up to 31,400 confirmed cases with 2,390 deaths, and the U.S. has 798,700 confirmed cases and 42,600 deaths. And the Trump administration and congressional leadership sounds like are getting near a deal on $300 billion funding for the SBA loan program and $100 billion for hospitals and coronavirus test funding. So with those updates, let's go ahead and dive into Michigan's Executive Order number 50. Next slide, please. All right, so what are we going to be talking about this morning? First off, we're going to be talking about this executive order and who it impacts. Included in the executive order are some new protections and reminders of protections for employees, and then some new protections for residents. And there is quite a bit of information contained in this executive order related to transfers and discharges of residents. So Tim will be digging into that quite a bit. Next slide, please. All right, so first off, who does this executive order impact? The executive order talks about long-term care facilities, and this is actually defined in the executive order as nursing homes, homes for the aged, adult foster care facilities, or assisted living care facilities. So that's really the group that we're discussing when we're talking about long-term care facilities. There are some provisions of this executive order that actually only apply to nursing homes, and again, we'll be digging into that in a bit more detail. There's also some kind of new terminology that was actually created by the executive order. So a regional hub is something that's been created by the EO, and this is defined as a nursing home that's been designated by DHHS as a facility to temporarily and exclusively provide care to COVID-affected residents. So this is something that's new. There's also something called an alternate care facility, and again, this is something that's defined under this executive order as a facility that's been activated by the state to provide relief for hospitals that have surged past their capacity. So almost like a relief valve here for hospitals that have exceeded what they're able to provide care for. And then obviously this also impacts hospitals. As we'll get into in a bit more detail, there are certain requirements outlined in this executive order related to transfer of residents or patients and discharges. So this will actually be impacting not only those long-term care facilities or those nursing homes that are outlined in the executive order, but then on top of that, hospitals that may be impacted because they're expected to create room and allow certain individuals to be moved into their care. Next slide, please. So let's talk just briefly about protections for employees. And this part of the executive order really is fairly minimal compared with all of the additional obligations that are placed related to transfers of patients and restrictions on nursing homes. So let's dig into this first. So protections for employees. So first off, this is a reminder of protections that have already been in place. Employees who test positive for COVID-19 or display one or more of the principal symptoms should remain in their homes as provided by that Executive Order 2020-36. And just a reminder on that, that executive order is the order that was issued by Governor Whitmer related to protecting employees who stay home when they're exhibiting either symptoms or they've been exposed to individuals who have tested positive or are exhibiting symptoms. And this Executive Order 36 was issued, I think, about a week and a half ago now. We actually have a webinar that we ran a week ago if you want to really dig in and get a bit more detail on this. But the most recent Executive Order 50 reminded employers that there are employees who are protected under certain sections of Executive Order 36. For purposes of Executive Order 50, what are we talking about when we're discussing principal symptoms? The executive order, it states that that includes a fever, an atypical cough, and I don't know what atypical is, that's not defined, and atypical shortness of breath. So when we're looking at what the symptoms may be, that's what we're looking at in terms of symptoms. Next slide, please. And then again, a reminder of Executive Order 36. Under Executive Order 36, an employer can't discharge, discipline, or retaliate against an employee for staying home or in their place of residence when he or she is at a particular risk of infecting others with COVID-19. And for purposes of long-term care facilities, the part of that Executive Order 36 that applies is when individuals either test positive for COVID-19 or display one or more of the principal symptoms, and we just talked about that. That's a situation where there's a fever, an atypical cough, atypical shortness of breath, until 3 days have passed since the symptoms have resolved and 7 days have passed since the symptoms first appeared or the individual was swabbed for a positive test. So what Executive Order 50 did is it reminded employers of those protections for employees under Executive Order 2020-36, clarified that certain parts of Executive Order 2020-36 apply to employees of long-term care facilities. And again, I would urge you, if you want a little bit deeper dive on that Executive Order 36 or a refresher on that, take a look at the webinar that we did last week, and that'll give you a little bit of additional information about the specifics of that executive order. Next slide, please. All right, so there are some additional precautions for long-term care facility employees beyond that earlier executive order. So first off, long-term care facilities need to take necessary precautions to adequately disinfect and clean their facilities. And as we've been saying throughout this whole COVID-19 journey, really what we're looking at there is we're looking at the guidance that's been issued from the Centers for Disease Control. That's what you're going to want to be looking at in terms of what precautions are necessary and what steps you should be taking to clean your facilities. So always go back to that CDC guidance, and I would urge you to check that on a regular basis for updates. As I'm sure you're all very well aware, this area continues to remain fluid, and it seems that, every day there is new guidance, new direction, new information that is issued. So on a regular basis, you're going to want to take a look at the CDC and see what is being recommended in terms of disinfection and cleaning. This executive order directs you to that guidance from the CDC, and that's what you'll want to be following to take necessary precautions. Next, this executive order outlines that employers need to use their best efforts to provide personal protective equipment, as well as hand sanitizer for all employees who interact with residents. Next slide, please. This executive order also outlines a requirement related to notification of employees about the presence of a COVID-19 affected resident. So what the executive order states is that as soon as reasonably possible, but no later than 12 hours after identification, employees need to be informed about the presence of a COVID-19 affected resident. And the executive order defines what they mean by COVID-19 affected resident. This doesn't just mean someone who has tested positive for COVID-19. It could mean someone who is COVID-19 positive, but it also means someone who is under investigation for the COVID-19 virus, or who displays one or more of the principal symptoms of COVID-19. And again, what we're talking about there, it's quite expansive, is a fever or an atypical cough or atypical shortness of breath. The other thing that this executive order requires employers to do is to notify employees of any changes in the CDC recommendations related to COVID-19. And again, as I said previously, there's constantly new information that is coming out as the situation continues to develop. So you'll want to, on a regular basis, take a look at the CDC website and see what information they've shared that you should be passing along to your workforce. Next slide, please. All right. And with that, I'm going to turn it over to my colleague, Tim, to start talking about some protections for residents.
All right, thank you very much, Kelly. As Kelly had said, I think the bulk of this order is really the biggest impact is going to relate to, protections for residents, and also perhaps even more so with respect to discharges and transfers of residents. So we're going to dive in here. I think one difficulty in even discussing this order is that, as Kelly highlighted at the beginning of the presentation, it impacts a number of different types of providers, long-term care facilities, and they generally have, fairly different patient or resident populations. A adult foster care facility has a very different population than a nursing home, and a assisted living center has a different population than a home for the aged. So it becomes quite complex how each of these provisions impact each of these different types of facility, but we'll do our best to dive in and give you guys as many answers as we can. With respect to protections for residents, this is fairly straightforward, I think, in the sense that these all pretty clearly how they apply to everybody, all the residents for the long-term care facilities. There's no eviction or involuntary discharge for non-payment at this point. Obviously, with people, the economy being so heavily impacted by COVID-19, people might not be able to pay for their parents or their grandparents, rent at an assisted living facility or home for the aged or nursing home. It should be a little bit less of an issue for foster care or adult foster care facility, but there will be impacts there as well. But the bottom line is that no evictions or discharges can occur due to non-payment. It doesn't mean that people don't have to eventually make payment. It just means at this point there can't be any evictions. So you can't deny a resident access to the facility based on, their COVID status, can't deny admission or readmission based on COVID-19 testing requirements, and also must inform the resident and the resident's representative of a transfer or discharge. I kind of found it interesting that you are required to inform the resident that they're being transferred, because I don't know how you would accomplish that without informing them. But these are some new and additional protections. It's going to be, I guess the bottom line is, in a long-term care facility, you really can't let a person's COVID status or potential COVID-19 status have an impact on how you treat them, whether you allow them into your facility, whether they're allowed to return to your facility. So, it's almost like a new protected class in some ways. All right, so if a resident obtained housing outside of the facility, I think for some early on in this, some residents left. I think families recognize, hey, this might be a nursing home, might not be the safest place for my mom or dad or grandma or grandpa to be located in. So let's bring them home. If they did that to try to keep them out of there, then they don't lose their right to return to the extent that it exists for other reasons, as if they have been hospitalized, for instance. And again, contracts are going to govern how this plays out, as will certain regulations, depending again on the long-term care facility. There's specific laws as to how a nursing home, if a resident is transferred out because of a health issue to a hospital, it's pretty strictly regulated how you have to let them back in and keeping their position open. So those laws and those regulations and contract language will applies even if they didn't leave for to the hospital or because they had health issues. If they just left out of their own choice, those same restrictions apply to those individuals. And again, you must accept a return if you can meet the medical needs, and also you have capacity as well. Additional protections, this has been in place for quite a long time, and it's something that I've heard a number of clients about. Residents leave, whether it was to visit family members. You have to screen the residents upon return for signs of COVID. You must cancel all communal dining. And, how do you accomplish this in an AFC? You're talking about oftentimes a home where there's a kitchen and that sort of situation. I guess a couple different ways you could have people eat in their room. You could also perhaps have people eat, depending on the size, maybe you can separate people 6 feet apart and you can have, maybe 1 or 2 people in, but you're obviously in a larger group home, you can't have, and especially in a nursing home or some of the bigger communities, long-term care facilities, you cannot have everybody sitting in the dining room eating at the same time. I believe most long-term care facilities have already stopped doing this, but to the extent they have not, they're going to have to figure out how to get everyone fed without doing so all at one time. As Kelley kind of addressed for employees, you also, you have to provide PPE and hand sanitizers for employees so that they, if they're having direct contact, so that they're not going to be spreading it to other residents. So in that sense, it's a protection for residents as well. You have to report cases to the health department within 24 hours. And you also have to keep inventory of the PPE that you have at your facilities, because the Department of Health it was either the Department of Health or the Department of Health and Human Services might request an update or some sort of report on what the status of your PPE is. And I think this will be, these PPE requirements are going to be tricky for some, in particular, long-term care facilities. That's not something that, say, an AFC is used to having around or necessarily has a supply chain to use. If facilities are having difficulties or they're looking at contracts, we're happy to review those contracts. We also do work with hospitals, and maybe we can help put you guys in touch with vendors that do have PPE available. I sort of get the sense that there's a little bit less of a crunch on PPE than there used to be, but it can definitely still be scarce as well. All right, you also have to clean and disinfect in accordance with the CDC. The CDC guidance, Kelley had kind of referenced this, but there's a couple different areas of guidance for people on the CDC website. There's some specific long-term care specific steps that don't really address cleaning and disinfection. And then there's also a specific guidance with respect to cleaning and disinfecting kind of community areas or community centers that I think would be helpful for long-term care facilities to review. With respect to their guidance for long-term care facilities, the CDC does say, you need to be scheduling a regular cleaning. You need to use EPA registered hospital grade disinfectants. So you're not going to be using stuff that you're just necessarily buying at the store. You need to focus on shared equipment, frequently touched surfaces in rooms, and common areas. And I think there's a certain amount of common sense to this, but I encourage people to go take a closer look at some of the CDC guidance. Again, I think this is something that long-term care facilities are already engaged in and have been doing for, probably at least a month plus at this point. So hopefully this isn't too much of a heavy lift. All right, so now we'll get into probably the more complicated and more difficult transfers and discharges topic. And this is where things are different for nursing homes in particular. And I think this is where most of the questions and issues arise. And just as a forewarning, the order that you guys have looked at is the same order I've looked at. You all are aware that there's a lot of undefined terms. There's not a lot of clarity on some of these issues. We'll do our best. What I've been trying to keep in mind, and when I'm having a discussion with clients, is that the goal and purpose of this executive order is to keep residents in nursing homes safe and to and isolate individuals who have signs and symptoms so that COVID-19 does not spread through these long-term care facilities. All right, so one of the things that you're required to do, transfer of effective residents or the creation of a dedicated unit. For nursing homes, this is the particularly unique component for nursing homes. If you're at less than 80% capacity, then you are required to create a dedicated unit. I get more into specifics about, how to do so and considerations related to that later on in the presentation. It's optional for other facilities if you're a nursing home with 90% capacity or you're a home for the aged or one of the other facilities, an AFC, then you have an option of creating a dedicated unit if that's something that you think you're capable of doing. One thing to keep in mind is that if you create a dedicated unit, you might want to think about staffing, again, for a nursing home that has medical staff regularly, as part of their employees. An AFC is not going to have a nurse or a physician necessarily that they're particularly familiar with at their facility that are working there, employed there. So you're going to want to think about, okay, if we're creating a dedicated unit, how are we going to properly staff that to keep residents safe? Because these are going to be individuals who are sick that have one or more of the symptoms. They're going to have a fever. They're going to have a cough. So you have to keep in mind, how are we going to do that if we want to create a dedicated unit? Who's going to care for these people? And then, so that's one option, is to create a dedicated unit, in which case that's where you're going to send and isolate all your residents that either are COVID positive or that have one or more of the symptoms that Kelly had outlined early in the presentation. The other option is that you are going to be transferring the residents. If you have a COVID-19 affected resident, and again, that means someone with a primary symptom, one or more of the primary symptoms, you must transfer them to a hospital if they are medically unstable. I don't think that's anything new for people. Obviously, people, long-term care facilities have been doing that for any number of reasons for a long time. Stable residents must be transferred to a dedicated unit if you have one and can provide the staff proper or appropriate PPE. Alternatively, and this is the order that you should be transferring residents, you should try to transfer them first to a regional hub. Is there a regional hub nearby? Is there a regional hub with capacity? The next option would be to transfer them to a hospital, and the third option would be to transfer them to an alternate care facility. And I address both regional hubs and alternate care facilities later. But there's only one alternate care facility that I'm aware of currently in the state, and that's the TCF Center in Detroit. what used to be Cobo Hall for those of us who are familiar with downtown Detroit. And I'm not aware of any regional hubs being identified yet. People can feel free to correct me if I'm wrong. Again, I'll address that a little bit more detail later. Again, so how do you transfer residents? This is a question that I've received from a couple clients, and frankly, my answer is that's a good question. There are no guidance. I think, or there is no guidance. I think with respect to, a medically unstable resident, using an ambulance, again, this is something that facilities have dealt with in the past. That's certainly an option. Do you use one of your own facility vehicles? Do you have a family come transfer them? What other options are out there? So obviously you need to consider liability issues are significantly increased if you're going to be using a facility vehicle or if a family is going to be involved. Other options include there are sort of there's medical transportation type companies. I suspect many facilities are familiar with these sort of entities. A lot of them, Medicaid will pay for this sort of medical transportation. So that's an option too. And one thing I mentioned a couple different times is I think it's important for long-term care facilities to start thinking about these issues, start planning these issues, reach out to transportation companies, reach out to hospitals, or try to collaborate and figuring out how to address some of these problems. Talk with families, have a conversation early on as far as how this sort of transfer will occur. The return of a resident. So you transferred a resident, they were sick, they've gone to a hospital or a regional hub, and now they're ready to return. So a medically stable resident can return. The ideal return is to their original facility if there's a dedicated unit and a PPE for staff and capacity. If that's not possible, then they go to a regional hub. If not, then to an alternate care facility. So I think this is one of the more confusing areas with respect to the executive order. I think so you have a medically unstable resident who's having difficulty breathing, who has other issues related to COVID, and you transfer them to a hospital. The hospital is fortunately able to stabilize them. The individual is improving, and so they no longer need acute hospital care. This is the order for which you would return those kind of residents. Again, I think we'll address here some of the conflicts in just a second. So the alternate care facility must accept if it has capacity. And then we start getting into, okay, so now the alternate care facility has capacity and the resident is ready to leave the alternate care facility. They must discharge the facility of residence if there's capacity. If the nursing home or AFC has since filled up since the resident was transferred, then they would go to a regional hub. And then if the regional hub does not have capacity or regional hub is able to sort of stabilize the individual, eventually they need to transfer that resident to the facility, back to the facility of residence. I think one of the problems with this executive order is you're going to have people who have symptoms of COVID and with this order, but may not have COVID itself. Maybe someone has a cough or some other respiratory infection for a different reason. Maybe they have a fever, but it's because of the flu or some other reason. This order treats all those people as affected residents, in which case, depending on your facility, you either have to send them to a dedicated unit, which is going to have quite possibly or will almost certainly have some COVID positive patients. So now you're exposing these people who might have COVID to people who clearly do. And the same would be true if you don't have a dedicated unit, you're transferring them to a regional hub or a hospital where there is COVID. Again, I think the message that this sends is that it's really important to protect, the rest of your population and to prevent the spread of COVID from within your facilities. All right, so what are these regional hubs and alternate care facilities? What is a regional hub? For those who have not seen, I'm happy you guys can reach out after the presentation or you can try and Google it, although it's a little bit difficult to Google. But MDHHS, not MDHHS, but Michigan Medicaid provided a policy that provides a little bit of information about what is a regional hub. It must be a Medicaid certified nursing facilities. Facilities must request designation as a hub, so you're more or less applying for designation as a hub, and it's just a temporary designation during the course of the state of emergency. What are the requirements to be a hub? Well, first of all, you need to have capacity. One way to do this is to block off a physical wing of a nursing facility. Another, as they kind of talk about in the executive order, is to sort of transfer all of the patients out of one of your facilities that maybe has a lower population and just use an entire facility and have that be either your designated unit or have it be a regional hub or both. So you must have capacity. They're going to also look at the proximity to hospitals. Understandably, if there's going to be COVID positive residents at these locations, it's going to be important not to be too far away from a hospital so that if someone's condition deteriorates, you can get them to a hospital quickly. They're going to look at the performance history. If it's a facility that's had, a lot of licensing citations, a lot of corrective action plans, then you're less likely to be selected as a regional hub. They're going to some sort of confirmation that you have sufficient staffing to handle the hub. They're also going to want to look at a plan for sanitation and sort of, as I mentioned before, the physical space. I think the physical space will be more relevant if you're using sort of a wing of a facility or just a portion of a facility as a regional hub. And if you're going to have an entire facility, I don't think the physical space will be much of an issue. All right, admission to hubs, you're going to pre-admission screenings, care determination criteria can occur after admission, so you don't have to jump through all the administrative hurdles. If if you're a regional hub and a nursing home contacts you or an AFC contacts you and says, hey, we have an affected resident here, we need to transfer them, you can kind of handle all the administrative and paperwork components after accepting the transfer. So payment and coordination, hubs will be responsible for notifying payers. So you're going to have to work with payers to make sure that they know they're insured, and so that they can start making payment to you instead of the other original facility of residence. Hubs will also be responsible for coordinating with programs like PIHP and other kind of state programs to make sure that everybody knows where these individuals are. There's really even less known about alternate care facilities. The order says they will be activated by the state. An example, as I mentioned before, is the TCF Regional Care Center that opened on April 10th. And at this point, I'm not aware of any other locations. I think obviously an alternate care facility is not going to be, that's located over in Detroit, is not going to be a particularly appealing option for clients here on the west side of the state. The idea of transferring a resident who has, a fever or some other symptoms of COVID and driving them 2.5 hours over to Detroit, what happens if the resident begins to deteriorate? And these are some significant liability concerns that I think are difficult to address or provide you guys with a simple solution. But obviously, I encourage people to if you're nursing home, you probably already have a relationship with physicians. That's probably less true for some of the other long-term care facilities. But I would think you're going to want to consult with a physician and see, try and get their opinion. Is this person safe to transfer? If it's 40 minutes, if it's 30 minutes, if it's 2 hours, kind of those are the questions that I would encourage people to think about. Maybe you'll be needing to have some sort of contract with a physician. Maybe they'll be willing to volunteer to do this sort of work. But I think, again, this is going to be particularly difficult for long-term care facilities that, generally don't provide much in the way of medical care for their residents. All right, so some facility-specific issues. As I mentioned before, this is a pretty diverse group of facilities that has been all labeled a long-term care facility, so there are some specific facility issues that I wanted to address for those on the phone who might run those particular facilities. Again, as you mentioned, for nursing homes with less than 80% capacity, you're required to create a designated unit. All right, well, what does this look like? First of all, and perhaps, maybe not most importantly, but very important, is you must provide PPE to staff on the unit. So again, you're looking at N95s, You're looking at possibly face shields. You're looking at gowns to put for staff to wear over their clothing. Again, the CDC provides guidance on what that PPE should look like. The CDC also provides guidance with respect to, I guess, rationing PPE and how to properly approach that. So in particular, you're obviously going to want to focus your resources to staff who's going to be staffing the dedicated unit itself. I think it would be smart, especially at least on a shift by shift basis, to not have staff who just have specific staff dedicated to the designated unit, so that they're not moving back to places where there's individuals who don't have symptoms, who are not COVID positive. You're going to want to keep, obviously the residents are going to be segregated and isolated, but you're going to want to do your best, at least within a shift, to, kind of isolate staff to that designated unit as well. So recommendations on how to create, one of the early questions I got on this was, okay, well, we don't have any positive or symptomatic or, affected residents as it's defined in the order. Do we need to start transferring residents to different parts of the building so that we have this dedicated unit set up? And my answer is, I don't think you need to be transferring residents. There's obviously danger in doing so. There's obviously inconsistency. There's obviously sort of just strategic difficulties for this. The other component of this, again, kind of goes back to one of my earlier comments. We don't know if you might be transferring someone from, somewhat isolated in their own room to another part of the facility, and that person might actually be asymptomatic but COVID positive. So now you're moving this resident into a location and bringing the COVID and the germs with them. So that's why, my advice is, if you don't have anyone with a symptom, then what you should be doing is creating a plan, identify a portion of your nursing home or your AFC or wherever you're creating this designated unit. Have the plan in place, identify where it's going to go, and then when you have your first positive or symptomatic affected resident, then you'll want to put that plan into place, in which case you'll, likely be transferring or moving people from one part of your facility to another. Again, I mentioned before, you're going to want to use dedicated staff for the unit. Use plastic sheeting to separate places or locations. If there's some way to have doors, then that would be even better, obviously. But even there, you're likely going to want to have some sort of plastic sheeting. Work with hospitals to develop a transfer protocol. As I said before, you might want to places that aren't used to providing any sort of medical care, especially to the extent that you're going to not just transfer as a matter of course, transfer every affected resident, and you're going to attempt to isolate them within your facility in some way, then I strongly recommend you work with hospitals or work with physicians to figure out how you're going to handle those situations. Nursing homes are going to want to work with hospitals to develop a transfer protocol. That's with respect to, if you don't already have that, with respect to medically unstable residents, or even if you don't have a designated unit, if you're unable to create one, with respect to just affected residents that need to be transferred as well. And the same would be, a regional hub as well. You might consider entering into some sort of agreement for that in order to kind of identify the roles for everybody, not necessarily payment, but also just so that they know that you would be sending residents to them. As Kelley had mentioned, the focus of this order is on long-term care facilities, but there's obviously impacts on hospitals as well. For example, they must accept medically unstable residents. They must accept stable affected residents, whether it's because that long-term care facility does not have a designated unit, or because the designated unit is full, or because there's no regional hub, or the regional hub is full. Hospitals are second on that list for receiving transfer of residents. And so I think this is where it gets confusing. Hospitals must discharge stable residents, so hospitals aren't supposed to keep these residents. This creates a conflict. So as we kind of mentioned earlier, so hospitals have to discharge stable residents, but as I just said, hospitals must also, they're number 2 on the list for accepting stable affected residents. So if a hospital gets the transfer of a stable affected resident, the order also says they have to discharge such residents. So I think there's some confusion there. There'll obviously need to be a common sense approach. Hopefully, this might be a moot point if regional hubs get up and running and there's enough capacity in those regional hubs to accept patients. Hopefully, most stable residents can just go to those regional hubs rather than having prolonged stays at hospitals. There's also questions about payment issues. I think that's one of the more interesting things. You know, these people aren't going to necessarily, some of these residents aren't going to meet sort of the medical necessity requirements for an admission to a hospital. How a hospital is going to be reimbursed for that will be an interesting component to see how that goes. Again, discharge residents in accordance with the order hospitals are, again, so there's a certain order with respect to where they're supposed to discharge each of these residents, trying to discharge them to the nursing home or the long-term care facility, and then if not, to the regional hubs, and if not, to the alternate care facilities. Again, as I mentioned before, hospitals should think about reaching out to long-term care facilities to discuss transfer protocols, to get an idea of, hey, how many patients, how many residents might we have, or might we expect from you guys? Are you guys having a dedicated unit, or are you just going to be sending stable people here? Because, again, that might also impact how hospitals decide to, maybe they'll have a floor for the unstable and a different floor for the stable residents who may or may not have COVID, all those sort of things. AFCs, HFAs, and assisted living, non-nursing home facilities must transfer medically unstable residents to hospitals. Again, so the order is going to be hubs, hospitals, or alternative care facilities in that order. Again, so the Medicaid Bulletin 2027 was the one I referenced earlier that discussed regional hubs and how to become one if you're interested. They seem to support keeping residents at facilities if they can be safely isolated. For example, it said may transfer. However, I reinterpret the order to require, in particular, any place without a dedicated unit, I interpret the order to require transfer of even stable affected residents. If you have a designated facility, then they can stay, or designated unit. If you do not have a designated unit, my interpretation is you must transfer those residents to, again, a hub, a hospital, or an alternate care facility. Again, AFCs, HFAs, and assisted living are going to need to procure PPE, as Kelley addressed, to protect your employees. So you're going to have to debate whether or not you should create a designated unit. If you're an AFC as part of like a broader network, is there a way to move some residents to a different facility? Is there another way? If it's an assisted living, depending on how you're set up, is there a particular part of your community that can be a dedicated unit where patients go or residents go? Or are you just going to take the position, hey, we're transferring all of these affected residents, whether they're medically unstable or stable, they're all being transferred to a hub or hospital or alternate care facility. One of the issues, and I'll turn it back over to Kelley, not on this slide, but at my last slide, relates to staffing issues. As Kelley discussed about 2036, there's sort of two different categories of employees that existed. There's one for people that were positive for employees that were positive or that they themselves had symptoms. Those individuals, those employees are protected under 2036, and you can't discipline them. So those we can call them paragraph 2 employees. And then there's paragraph 3 employees. And those were individuals who had sort of close contact with people who were symptomatic of COVID. And employers were prohibited from retaliating against those people if they stayed at home. But there were some exceptions. Health facilities, workers of health facilities were excluded, as were healthcare professionals. However, AFCs and assisted living center homes and communities did not meet the definition of health facilities. And while some of their employees might have been in healthcare professionals, some of them would have not. A lot of the direct care workers are not RNs, they're not licensed healthcare professionals. So in light of this order where these employees of AFCs and assisted livings living communities are going to be required. As you know, if you're transferring someone, you're going to have employees who are in close contact with residents who have symptoms. So I think one thing, AFCs and assisted living centers should think about is perhaps we can take a more aggressive position on what is defined as a healthcare professional under 2020-36. That would mean that you are able to have a little bit more leverage when just for employees who only have close contact. Again, regardless, every employer, if an employee is positive or has symptoms, those employees are supposed to stay at home. However, when it comes to someone with close contact, there's a little bit more options for health facilities or healthcare professionals. And so I think AFCs and assisted living centers are going to need to think about who they're going to designate as a healthcare professional under 2020-36. Perhaps direct care workers, you're going to want to take the position that they're healthcare professionals so that you can keep staffing your facilities. But again, like a secretary or receptionist or some other individual without direct contact, you're probably not going to want to take that position. And that's something, if you want to reach out, we can help provide guidance to clients. All right, other issues and uncertainty. What if a resident has a medical directive that prohibits transfer to a hospital? So one of the requirements was that if you're transferring a patient, then you need to include, or a resident rather, an affected resident, you need to include their advance directive. All right, well, what if that advance directive says, do not transfer me to a hospital? My advice to clients is that you should send those people to the hospital, even if their advance directive says do not do so. The purpose of the EEO is to prevent the spread of COVID-19. If someone has symptoms or tests positive, you need to either send them to the dedicated unit. If you don't have one, you need to be sending them to a hub or to the hospital. I think, you just need to make sure that you include the directives with the resident so that if the resident is going to a hospital because there's no regional hub near you or there's no regional hub with capacity, then that way the hospital knows about the advance directives and knows how to treat the resident. Again, as I kind of teased before, transfers are going to raise many, many issues. What about transfers within the facility? I think while this order is well-intentioned, transferring, everybody knows on this call that it's not so easy to transfer. If you're a nursing home, you're dealing with fragile patient population. If you're also dealing with a considerable number of, if you're in a homes for the aged or an assisted living community, you're dealing with a lot of personal property. Do you leave the personal property there? Well, probably not if you're going to use that room as a dedicated unit. So how do you carry this out? What if you only have like double rooms versus single rooms? Or what if you are sending them to a lower, a smaller apartment that would normally be charged less rent? You need to be adjusting rent. So these are all a whole number of issues that, the order doesn't really provide any guidance for. That's going to be difficult for all these long-term care facilities to transfer. If you're an AFC, moving people, you're dealing with individuals who often have had traumatic brain injuries. You're dealing with people who have significant emotional disabilities. And how are you, it might not be easy or even possible. It's going to be very difficult, these sort of transitions for some members, some people living in AFCs. And again, there's safety concerns. I used to do medical malpractice defense early on in my career. There's concern what happens if an individual decompensates, if their condition worsens during the course of a transfer. Again, this is where hopefully you're able to consult with a physician. If not, then you're going to want to have some contingency plans, know where the local hospital is. If you're transferring someone to a regional hub, have an alternate plan. What do I do if this person begins to deteriorate? Maybe you're able to get some oxygen within the vehicle that you can take with you in case there's some difficulty breathing. Again, these are a lot of difficult questions where the EO is completely silent about. Again, return of residents. I think this is where things become very confusing. Hospitals and regional hubs are supposed to send patients, return residents back. Let's say if the person still has symptoms and they need to go to a dedicated unit, If they're free of symptoms, they've completely recovered, it's been 3 days since they had any of these symptoms. Again, I do believe you're going to want to isolate or quarantine these residents in their old room to the best of your ability. Again, this is where this order impacting so many people and so many different types of facility is difficult. That might be somewhat easier to do in, say, a home for the aged or a nursing home or even assisted living facility. I think it's going to be particularly difficult for an AFC to isolate these individuals. COVID-19 testing rules have been altered. The MDHHS issued some guidance, revised guidance, and it really is prioritizing residents of long-term care facilities. So I encourage individuals, again, you can reach out to me and I'm happy to have a discussion or forward the information to you. But the bottom line is I encourage people to be aggressive with having your residents tested so that you can quickly assess, if someone has a fever, if it's a low-grade fever, you should be able to get them tested pretty easily and pretty quickly. So consider doing so. That way you know what you're dealing with. Maybe they're negative and it's just a flu and you don't need to transfer them out of your AFC or your other facility. That way, you can just keep them sort of separated while you continue to monitor them and make sure that you're able to medically care for them. And so this is where I'll bring Kelley back in here. I kind of talked about the staffing of a designated unit or staffing issues in general for a lot of these long-term care facilities. That's an issue we've gotten lots of questions on. As I said, I think, AFCs or other places that are not healthcare facilities, so long-term care or sort of assisted living communities and AFCs, mostly we're talking about here, you might need to be aggressive in taking the position that your staff are healthcare professionals, at least your direct care staff, so that you're able to have sufficient staff. And again, I've had conversations with clients about some of these issues already, even before this, as far as taking, balancing the need to protect the residents of your given facility by having enough staff versus meeting some of the licensing requirements, whether it's fingerprinting, criminal background checks, or with respect to 2036 and having people go home. So, if you're getting pushback on staffing some of these designated units, you're a nursing home or one of these other facilities that are going to create a designated unit, staff are saying, I don't want to staff that. I'll have Kelley can kind of weigh in here and provide you some advice, some things to think about when you get some of that pushback. So Kelley, if you want to weigh in.
Yeah, thanks, Tim. As Tim mentioned, we've been getting a lot of questions from clients about difficulty staffing, right? People are scared. They don't want to report to work. They have concerns. So, as I think about that, what I think about are, a couple different approaches that kind of go hand in hand. One is incentivizing. So communicating to employees all of the steps that you've taken to keep the work environment safe, all the additional steps that you've taken related to sanitizing, that you're complying with the CDC requirements, that you have provided personal protective equipment, and then possibly considering some sort of additional incentive. A term that's been thrown around a lot that I don't really like is hazard pay. The reason I don't like that term is because I think it kind of feeds in to the fear around this issue. But the idea behind it of providing some sort of additional compensation for people who are working on those units is something that you might want to consider. And then the other side of it is, taking action against employees who are refusing to work. So I think it gets complicated. It's not necessarily, a black and white. Someone says, no, I'm not going to work in that unit, and then you take the next step. You need to really take a look about why those individuals are saying that they don't want to work. Is there some reason that they're providing that is protected under state law. So again, we've got all those executive orders that we're considering, or possibly federal law. So you need to kind of work through that analysis and take a look at why it is that the individual is objecting. Make sure that it's not for a protected reason. And then after you've done that analysis, you may be in a position where you need to start kind of walking down the road of corrective action. And whether that means having a conversation with the individual, if your staffing allows it, letting them possibly be off on some sort of leave, or if you need to start working through possible other corrective action like a termination. And again, you want to be careful when you're making those determinations. Like I said, there are a whole lot of executive orders that are at play. There's the regular federal law. And then there are additional concerns you might want to think about related to potential OSHA claims or even claims under the National Labor Relations Act. So you want to be careful when you do that, but you can, obviously, within your wheelhouse, you do have the right to take disciplinary action up to and including termination if employees are refusing work. The other thing that's weighing in on this is obviously unemployment. We're seeing many clients who are having difficulties because people actually want to be off on unemployment. They may actually be making more with the federal supplement than they normally would be just given their normal income. So that's creating some challenges as well. One thing that we've been communicating to clients is that obviously you as the employer don't control unemployment eligibility. That's a determination that is made by the agency. However, you as the employer also have an obligation to respond truthfully when there's an inquiry about why someone is off work. And in order to get unemployment at the state level and therefore that federal supplement, individuals need to be eligible for unemployment under state law. So if someone has work available and they have refused that work, and the reason they're refusing work isn't for a covered reason under the unemployment law that would allow them to have those additional protections as we go through this COVID-19 period, they may be found ineligible. And again, that's something that you as the employer don't control, but it can be something that you can remind employees of as they're kind of weighing in their mind what they want to do related to continuing to work. So again, it's going to be kind of a fact-specific analysis, and you want to be careful as you're taking those steps. But those are some things to think about when you're thinking about staffing. And with that, Tim, it looks like we have a question, and I think this one's for you. Let me just reread this. So residents should be transferred even if against their advance directive if they are medically unstable. But if the nursing home has a designated unit and can contain the virus, can they stay there?
I think if they're medically unstable, I think the answer to that is no. If they are medically stable, if it's just an affected resident showing, has a fever or something like that, then yes, I believe they can stay at a designated unit within a long-term care facility. I think the only time you really need to override, so to speak, a advance directive that says do not send the resident to a hospital is if the person is medically unstable, or you don't have a dedicated unit, way to isolate the patient, in which case the individual must be transferred, is my interpretation under the order, even if their advance directive says otherwise. One thing I did want to mention, I talked about the 20-20-36 for, and healthcare professionals for AFCs and assisted living communities. I will say, I mentioned one possibility is taking a more aggressive position with respect to some staff members being healthcare professionals. There is some risk related to that I want to make sure that I highlight to people that, there's a potential fine for violating 20-20-36, and there are also potential licensing actions related to that as well. So I think it's a very case-by-case specific situation. I think what has already happened for many long-term care facilities and has been occurring throughout this process, I think it's to the best of your ability, try and stay in touch with your licensing consultant, try and identify problems before they arise. You know, if it's looking like staffing shortages might become an issue, reach out to your licensing consultant to let them know and see if they'll be willing to work with you. If they're not, then, you know, please reach out to one of your attorneys here at Miller Johnson, and we can help walk you through the different risks and help provide some, you know, the legal justification for whatever steps you guys are considering. And I think hopefully Laura and some clients have already said they've reached out to Laura, you know, and their licensing consultant with questions related to 2050. They've been told that Laura is hopefully going to provide some guidance. I mean, this order came out late Thursday night, and it's already Tuesday, and we don't have any guidance other than the policy from Michigan Medicaid. So hopefully we'll get that soon. But if not, then again, you know, Kelly or myself or others here at Miller Johnson are happy to help work through this process and give you the best legal direction we can in light of some of this uncertainty. So with that, I don't see any additional questions. What if a resident is on hospice? Was another question that just came up. I guess I'm not exactly sure. I guess, so they're on hospice. They're medically unstable. Again, I think at this point, I think it becomes a question of, if they're on hospice, I think it becomes a question of whether or not you can properly isolate them and keep protecting the rest of your population. Again, it's important to protect everybody else and prevent the spread within your facility. So I think whether or not you allow that patient to stay if they're on hospice, then would be up to, you know, your ability to keep everybody else isolated and prevent the spread through your facility. So I do think, you know, hospice is kind of, I think, a different situation than someone who has sort of an acute medical instability, you know, who suddenly can't breathe or has COVID-related symptoms, in which case I think you would need to transfer that person, as opposed to someone who's on hospice who has a long-term care issue. Again, and the other thing is to discuss this with family members, document any sort of consent that you might have from them with respect to keeping them at the facility, and work with them. That way you can help, you know, make sure that no one's upset or no one disagrees with your transfer decision or decision not to transfer them. And, you know, again, have discussions about your concern about the spreading and getting other people infected within your facility. All of these long-term care facilities have, really all of them have a vulnerable patient population. So I think in light of this executive order and the exigent circumstances that we're all dealing with, that we need to be a little bit more flexible in some of these advanced directives or patient request type issues. It's more complex than that now, unfortunately. So that's the only other question I have. So we appreciate everybody joining us today. Again, if you have questions, I encourage you to reach out to either me or Kelly or your other Miller Johnson attorney. And I hope that everyone stays safe. Hopefully your facility avoids needing to take any action under this executive order. But if you do, we encourage you to plan now, and we're happy to help you with those plans. So stay safe, everybody, and have a great day.